All right, this is going to be a fairly quick lecture on burns and complications in infants. So we're going to jump right into talking about thermal injuries or burns. They can be very damaging to the skin. Burns can affect the epidermis, the dermis, hair follicles, and glandular tissues. And there are many categories to the types of burns, and we're going to go over the ones that you should focus on in a minute. So during a thermal injury, there is a risk for decreased perfusion at the area of coagulation. The damaged tissues will release vasoactive mediators, and then fluid moves to that interstitial space around the burn due to increased capillary permeability. Burns can occur from sources such as heat, electricity, friction, chemicals, and radiation, like a sunburn, and the extent of the burn is determined by the depth of the tissue involvement. So here's kind of a graphic about the different layers of skin and what degree of burns we're looking at. Superficial burns are considered first degree with damage just to the epidermis. So in this case, the skin is intact and there's moderate pain. You're not going to have any blisters with this first degree burn, and it will heal without scarring. So this would be something like a sunburn. Superficial partial thickness or second degree burns will occur at that upper part of the dermis, and you will see blisters. You can also have a deep partial thickness, which kind of affects the lower dermis level, which you'll end up then seeing some yellowing at the burn site with that level of burn, and we'll start to see some scarring beginning at that level. These types of burns are usually caused by major sunburns or skin contact with hot fluids like immersion burns. Then a full thickness burn or third degree burn extends into the subcutaneous tissue. Okay, this burn can be white or brown or black in color. It's going to be dry and leathery, and you can see kind of as indicated in the graphic here, it's got a darker color in your vertical column. If the nerve endings are damaged, then you're not going to have any pain with this burn, okay? Burns are usually caused by developmental reasons. So for infants, oftentimes you will see burns due to maybe overheated formula or milk bottles, or they get burns in their mouth. Hot bath water can definitely be a risk, or being held by parents who are near heated objects such as stovetops. Toddlers will usually have burn injuries from flames like campfires or an active stovetop, or if they grab something on the counter and they flip it over and it lands on them. As well as electrical hazards such as unsecured outlets or wiring. And then older children and adolescents will usually have burn injuries that are related to risk-taking behaviors or to their employment, but they are still at risk for all other burn types as well. It's important to note that the highest risk of burns in pediatrics is due to lack of supervision, but as always, with any sort of unintentional injury, we do want to keep an eye out for abuse because that does happen as well. And so making sure that we're taking a good history and reporting anything if it seems like the stories are not lining up or do not fit with the type of injury that has occurred. So to diagnose burns, that's usually based on clinical presentation, and we will use the Lund and Bowder chart rather than the rule of nines, if you remember that from MedSurg, because this is more accurate for peds. It accounts for variations in their body shape with age. So the breakdown isn't quite as easy to memorize, but good news, not requiring you to, okay, primarily because it differs based on age. And so you can see in this graph at the bottom of this slide, there's different percentages based on if the child is an infant or 1 or 3 or 10. But this can be much more accurate unless, of course, we have some lateral burns, for example, because if you see that this image really only takes into account anterior and posterior sides of the body. So if there's a lot of lateral burns, it could be a little bit more difficult to estimate, but this chart still results in greater accuracy than the rule of nines for the pediatric population. With major burns, we would also do labs like a CBC, a CMP, a BUN, a creatinine, a blood gas, a urinalysis, and a lactate because we want to monitor organ function. And then we might even do imaging if necessary, depending on the location of the burn. So how do we treat burns? Well, minor burns are treated with cooling, okay? Cleaning, preventing infection, so washing with some cool water or tepid water and mild soap, and controlling pain. Pain and itching can be treated with over-the-counter medications like Tylenol, ibuprofen, or Benadryl. Moderate to severe burns will require treatment by a provider, and any clients who have them should be transferred to a hospital immediately. We definitely want to assess our airway, breathing, and circulation. We want to provide fluid resuscitation, pain management, wound care, and tetanus boosters as required. The wound care, is generally done with silver sulfadides diazine, I can never say that word, and that's used to prevent infection. Pain management will be using things like morphine and fentanyl because usually these are, depending on the percentage of body surface that is covered, burns can be incredibly painful. These patients will usually go to a burn center, so it's not something that you're likely to encounter clinically unless you specifically go work in a burn center. But if there is a severe burn, we can do an escharotomy where we remove that eschar or that dead tissue to help relieve pressure and increase blood flow. It's kind of similar to a fasciotomy if you think about it. They kind of cut into the tissue and let it sort of spread and kind of open up, and then they clear out that old tissue in there. They can also do hydrotherapy, which performs some of the same functions. These procedures should always be preceded by pain medication administration. They're incredibly painful. We want to educate the families on a high quality protein-rich diet during healing, and then also educate them on any dressing changes that are needed, as well as further education and anticipatory guidance about burn prevention. My slide's not changing. There it goes. So we're going to move right on to common infant complications, focusing on respiratory distress syndrome and hyperbilirubinemia. We're going to explore their causes, their clinical presentations, and the essential nursing care. So respiratory distress syndrome builds on what we already know about respiratory conditions in children. RDS generally occurs as a result of surfactant deficiency in the lungs, which is characterized by poor gas exchange and ventilatory failure. Now, looking at the presentation, you can see that this looks incredibly similar to respiratory distress from other causes, so don't overthink it, okay? Respiratory distress syndrome is more common in preterm babies, those who experience perinatal asphyxia, for example, or other complications during birth. So care for RDS will involve airway management and monitoring the respiratory status. Most complications from RDS actually occur due to the effects of ventilation. So things like pneumothorax, bronchopulmonary dysplasia, infection, intraventricular hemorrhage. So these patients really should only be supported as much as they need because their lungs are so fragile. We really can cause more harm than good if we overventilate and oversupport these patients. Okay, moving on to hyperbilirubinemia. We've got two types of jaundice. Physiologic, which appears after 24 hours of life, and that's generally benign. Or you can have pathologic jaundice, which appears before 24 hours, and that is actually usually caused from an underlying issue, usually like an Rh or ABO blood group incompatibility. And so for those babies, if we suspect that we're having those issues, we're going to identify with a Coombs test and treat that accordingly. Physiological jaundice is much more common. Signs of jaundice can be seen when the bilirubin level is about 5 milligrams per deciliter or higher. And we just want to make sure that we are treating it because if you do not treat high bilirubin levels, you can cause a neurological complication called kernicterus, where the bilirubin will actually deposit into brain cells and then cause neurological damage. So jaundice is usually identified within the first week during a follow-up PCP visit after birth. They can check the levels transcutaneously, and then they'll follow up with a direct blood level if they're concerned. Usually you can see it in the eyes. Skin tone is different, so we can't always see jaundice depending on the skin tone of the child, but usually you will see some scleral involvement and notice that they do look a little bit yellowed. Patients will usually come to the hospital for light therapy if the levels are over 12, and this is a pretty straightforward process, but there are a few important things to remember. So babies are not great at regulating their temperature, okay? And so when they're under Billy lights, if you see in this picture, they're in only a diaper because we want maximum skin surface area to be exposed to the light. So we're really doing frequent checks on temperature and skin dryness, and just overall, how intact their skin is because of the effects of the light therapy. They also need eye protection. Okay, so you can see this baby has a little eye mask on. So every time you go in and you check, you want to make sure that those masks are on correctly. Bilirubin is excreted through the kidneys and the liver. So hydration really is key to clearing the excess. And oftentimes breastfeeding can actually impact Billy levels because milk takes a while to come in. And so the infant may be more dehydrated in the first few days of life. And this can actually exacerbate a hyperbilly issue. And is oftentimes when these kids come in, they usually are breastfed. And it's because they just have not had enough fluid to flush things out. We will also be monitoring labs at regular intervals to ensure that they are dropping as we expect. And usually once they get under about 12, they won't rebound and come back in with any issues. So while it is usually treated easily from a clinical standpoint, this can be very stressful for the parents. Okay, these babies are usually under a week old, so the parents are still adjusting to their new roles, and mom is recovering from delivery. So since that infant must be under the lights as much as possible, parents really need some education and reassurance on handling. They need to be told that the baby should only come out to eat, but at that time, that eye mask should be removed, and parents should really engage with the infant as they would normally. They should also be encouraged to touch and talk to the infant even when the infant is under the lights. Oftentimes, newborn education also happens a lot with these families, especially since feedings sometimes will change depending on intake and output. You'll see lactation consults or even formula supplementation that may occur, and this can be unexpected for the parents. These babies generally have good outcomes and go home after about a day or so, but that doesn't, really help with the immediate stress that the parents feel at unexpectedly being in the hospital. So moving on to peds emergencies, we're going to focus primarily on respiratory emergencies, which is, again, a bit of a review, brief resolved unexplained events, and sudden unexpected infant death, okay, which is what SIDS is now being kind of categorized with. So jumping right into respiratory failure, I found this graphic, and it really breaks down the risk factors that are outlined in ATI. You don't need to memorize this, but just be aware of what systems can cause respiratory failure in peds. I think it's helpful. ATI focuses on restrictive lung diseases, obstructive lung diseases, and primary inefficient gas exchange due to things like asphyxia, CNS involvement, or trauma. All right, remember these? The signs and symptoms of respiratory distress from so long ago, they are back. So prompt recognition of distress can prevent escalation to failure or apnea and eventually arrest. While many things can cause the following symptoms, we can always rely on our response being the same, right? Say it with me now. Airway, breathing, circulation, and what is it? Does this look familiar? It's our good old BLS algorithm, okay? In addition to this, the chapter includes what to do if a child is choking, and that varies based on age. So recall back to your first aid CPR certifications that we do back blows alternated with 5 chest thrusts or compressions, and that's repeated until they expel the foreign body or they are unconscious, at which point you would move to this CPR flow on this slide, which is also what you would do if you were in the hospital and a child went into respiratory arrest, right? If the child is a bit older, you would do the Heimlich or abdominal thrusts for choking, and then again moving into your BLS single or double rescuer depending on who is at the bedside with you. Now there are 2 acronyms in this chapter you're probably not familiar with, so they are important though. BRUE, which is the brief resolved unexplained event, and SUID, as I mentioned before. So a BRUE used to be called an ALTE, A-L-T-E, which was an acute life-threatening event, and they have renamed it. This is where an infant is observed to have apnea or a change in color or some other scary behavior, usually reported by the parents, and they seek medical care. So sometimes it ends there. Maybe we don't see anything during observation, and so we just watch it for a bit, and then they go home. Other times the incident will repeat itself, and now we are looking into why. So these behaviors can be common in some infants, like preemies, where they'll have these apneas and bradycardias. The NICU world calls them A's and B's, and this is usually due to an immature central nervous system that just doesn't remember to do what it should. If we are concerned about an underlying issue, we will usually do some more investigation. So we would grab some labs, we would check for a UTI or an infection, because those generally are what would cause strange symptoms like this. We could also dive a bit deeper with like an EKG, an MRI, a sleep or swallow study. I cannot begin to tell you how many of these admits actually turn out to have reflux. And that's not intended to minimize the condition at all, by the way, just to sort of highlight how fragile some of these babies can be and what can set them off in ways that scares the pants off their parents. My daughter was a 29-week twin, and she went home on an apnea monitor due to some lingering A's and B's that she had had. And we actually had her on caffeine for a few months because it needed to keep her brain awake and to remind her to breathe while she was sleeping. So it was definitely a stressful time, but thankfully she outgrew it. However, some babies aren't as lucky, and some have more serious issues going on, and that's what leads us to talking about sudden unexpected infant death. So SUID, as I mentioned, is the new acronym for SIDS. This is defined as the unexpected death of an infant with or without an identified cause within the first year of life. So SIDS is one of those preventative education points that I think every nursing student's aware of by now. It's the cornerstone for much of our infant education. So we hear about it in PEDS and OB and probably other courses. Prevention measures like putting babies on their back to sleep, using a pacifier, not bed sharing, keeping things out of the crib, not letting them sleep in swings or car seats. There's also some less obvious prevention like avoiding smoking, preventing overheating, and getting immunizations. So there are several risk factors, and you can review them in your book, but some of the more common ones are maternal smoking during pregnancy and exposure afterward, co-sleeping, like I mentioned as one of the preventions is not to co-sleep, improper positioning during sleep, low birth weight and prematurity, as well as family history. Obviously, the death of an infant or any child is incredibly traumatic for the family. Families need compassion, understanding, and practical assistance during this time. Sometimes the death of an infant can be coupled with an investigation, depending on the circumstances of the death. And so this can compound an already stressful situation. And it's important that nurses and providers remain non-judgmental in their communication with the family. We want to answer questions honestly and refer them to support groups and community resources as necessary. On that note, you have come to the very end of your very last lecture for this course. Best of luck on your final, and I will see you guys on the other side.